Yeah, Raju.
Sir.
Yeah, it is live now.
Okay, sir. Yes, sir.
It will be seen there also. Once we are I mean, it will be there forever like that.
Okay, sir. Yes, sir. Nice, sir.
Yeah, Raju,
Yes, sir. Admit Martin, sir.
live now.
Okay, sir. Yes, sir.
Oh, 1 minute.
It will be
I think that
seen
is
there
getting
also.
echoed. Once we are I mean, it will be there forever like that.
Yes, sir.
ಇಲ್ಲ ರಜನ
Sir, here is.
ಇಲ್ಲ ಅದು ಆ ಕಡೆಗೆ ಇದಾಕತ್ತಿತ್ತು. ನಾವು ಐ ಥಿಂಕ್ ಇಟ್ ವಿಲ್ ನಾಟ್ ಗೆಟ್ ಎಕೋ. ಯಾ.
Okay, correct it, sir. Yes, sir. ಚಲೋ ಐತಿ.
ಹಾ. ಮಾನ್ಸ ಮಾನ್ಸ hello.
ಮಾನಸ
She has come, but she's not speaking.
ಅನ್ಮ್ಯೂಟ್ ಮಾಡಕ್ ಹೇಳತ್ತೀನಿ
Hi,
ಸರ್.
sir. Hi. I can hear you guys.
Yeah. So, you are speaking on contraception, no?
No, sir. No, HPV vaccine.
Okay. Who is going to start first?
Anyhow, it's okay, sir. I can start.
You are going to start?
Yes, I'll start.
Okay. Shall we start?
All have come, sir. I cannot see.
No, I mean, see what
Yeah,
happens is we have
yeah,
already
we'll start.
already made it live on YouTube.
YouTube. Okay.
So it will be live, and after that, this webinar can be heard there also. I don't have to record this and then edit and post it there. So we'll
Okay,
make a
sir.
habit of starting in time and record it and leave it on YouTube, so it will be there.
Okay, sir. Done.
So why don't you start?
Sir, no, I'm not able to share the screen. Like host
Yeah,
is.
I'm sorry. I have to allow you 1 minute. Yeah, now you can.
Can you see, sir?
Yeah.
Shall I start?
Yeah, we can start.
Okay. Good evening, everybody. I'll be stating some facts regarding the HPV vaccine. As far as the CDC guidelines are concerned, these are the recommended guidelines to be followed. The recommended age group is as follows. The routine vaccination has to be done between the age of 11 and 12. It can be started at the age of 9 as well for both boys and girls. Whereas the catch-up vaccination period is from age 13 to 26, which is recommended for those who are not vaccinated earlier. Whereas 27 to 45 age group, it is not recommended, but anyways, it can be discussed and then once concluded regarding the and after considering the potential benefits, it can be come into a conclusion whether the patient should be vaccinated or not. And the schedule is as follows: between the age of 9 to 14, there are two doses has to be given, that is 6 to 12 months apart. Whereas 15 to 26 years of age and also all age group who are immunocompromised individuals, the dosages of three, that is first dose and then second dose between 1 to 2 months, and the third dose is after 6 months. The benefits are it prevents mainly HPV related cancers such as cervical, vaginal, vulvar, penile, anal, and oropharyngeal cancers, and also reduces the occurrence of genital warts. The absolute contraindications are as follows, that is severe anaphylaxis to the prior doses, and also in pregnancy it is not recommended. But if a woman is found to be pregnant after starting the vaccination, the remaining doses should be delayed. But there is no indication for termination if she gets to know that is pregnant after taking the vaccine. And also with individuals with moderate or severe acute illness, the vaccination has to be delayed until they recover. Special considerations are in immunocompromised individuals, though there is weakened immune system and they may not respond well to the vaccine, it is still recommended because they are at higher risk of HPV related diseases. And also it can be given to the breastfeeding women. Regarding the safety, which is of main concern, data from various clinical trials and ongoing research show that it provides long-lasting protection. and the protection lasts for more than 10 years without becoming less effective. Studies are ongoing to further evaluate the duration of protection. Until now, there is no data which indicates that protection from HPV vaccine lessens over the time. And the currently available vaccines are as follows. That is bivalent, quadrivalent, and the Gardasil 9. And the costs are as follows. Cervarix, which is bivalent 16 and 18, costs around 2,500. Gardasil 4 is around 4,000. Gardasil 9, which is a nonavalent vaccine, it is around 11,000. Cervavax, which is manufactured in India from the Serum Institute, is around 1,500. And the route has to be intramuscular, but that is 0.5 ml. And the individual should be observed for 15 minutes post-vaccination, as fainting is commonly observed. This is it.
ఎవరేమో కూలింగ్ తగ్గుతుంది
Mansa, I have a few questions.
Yes, sir. Yeah.
Yeah. Number one, like now, if you see all these four which are
Yeah.
available,
Yeah.
now, I mean, like, if at all you have to make one recommendation, which would you say you go for it? Gardasil or Cervarix or Cervavac? Can we go
So
back to
yeah,
can we
yeah.
go to the slide and just ask few questions only.
This one, sir.
Yeah. Hello.
Yeah. Sir, I think Gardasil 4 is time tested and
Yeah.
also cost effective. So I would consider Gardasil 4.
Okay. Number one.
Cervavac is a recent one and not many trials are there yet.
Yeah. Okay. Then the second question is, now see what has happened is many people have now come in. Sorry. They have made aware of the cervical vaccine, cervical cancer vaccine.
Yeah.
Even those who are perimenopausal or postmenopausal women, they are coming and asking, or married already 10 years, 15 years, and they already have children and all that. Would you still recommend the vaccination?
Sir, I personally do not agree with that. I would still consider screening as a better option than giving vaccine because you're not stopping the screening method for that age group. I feel after reading all this and the mechanism, how it acts, it is the most beneficial when you're given the vaccine to individuals prior to the initiation of their sexual activity.
Okay.
Otherwise, every 1 and 2 individuals would have HPV infection. And most of it is self-limiting, sir. Around 75 to 80% of the cases.
Yeah. So,
But
your answer contains, actually two answers. Number one is we cannot stop screening despite taking the
vaccine.
Okay.
Yeah.
That is number one. And number two, those who are already sexually active and probably have had children and probably have had infection because it is quite prevalent infection. So probably vaccination will not help. But if somebody, see, some patient was asking, what if I get the HPV DNA test done? And if it is negative, should I take vaccine? What is your answer?
That can be considered, sir.
Yeah. So, okay. So what I feel personally is that it is best to start much before they actually become sexually active. So in our practice, the moment they enter the high school, that is 8th standard onwards, which they will be around 14 years, that is the best time to usually, vaccinate them. Second thing is, we have to tell them in future that just because you have taken vaccine doesn't mean that you will not get a cancer. So screening will continue no matter what. Okay. This has to be made. And now last one is that.
Sir, I have, are you completely convinced about the safety of the vaccine?
Exactly.
Uh,
That is another question I wanted to ask you, because there are reports where, deaths have been reported. And when they have done mass vaccination in schools, many have had trouble, like, fainting and vasovagal thing, or even, what do you say, what is that, anaphylactic reactions and all that. So
mm,
no matter whatever, see, the drug which you take, okay,
yeah,
can cause allergy, can cause problems.
yes,
Okay, so that is why you say, you have to, the benefit versus the adverse effects, you have to weigh, and then only we have to recommend. But nevertheless, because HPV vaccine now coming, we should know all these facts when you discuss with the patient. So we
okay.
have to explain all these things and then give. Okay. Another question. Would you recommend this to boys?
Yes, sir, we can. I mean, all those wards and all that can be prevented.
Yeah. See, I think in our country now, because it is a, what do you say, now we are resource, you know, not very resource rich country, where there are constraints about our resources and how much we can spend on these vaccines. So somebody affordable patient, if they ask for it, I think we can recommend, because
Mm,
now IAP, I just saw the guideline recently,
mm,
which I'll send it to the group. I think I already
mm,
sent it to the group,
mm.
where they have recommended to boys also.
Voice
Okay.
also, yeah.
Yeah. And again, age group is similar. So
Mm,
it prevents, probably it prevents them being a carrier,
mm,
apart from prevention of the warts. So these
okay.
are the two things which we should consider uh, about the vaccination of the boys. Okay.
Yes,
Now,
sir.
though not related to the vaccine per se, but the cervical cancer screening, okay, wherever you have the facility, like in Bengaluru
Mm,
and
mm,
other places,
mm,
where
mm.
now liquid-based cytology is the best, okay,
Yes.
and now the HPV DNA. See,
Mm,
now what has happened is, one of the patients, she came with a report of ascus, okay. Now, I being practicing in a rural place, immediately I told, okay, probably this will be normal, but you need to get a colposcopy guided biopsy.
mm,
But the consultant there in Bengaluru has recommended HPV DNA.
mm.
Now, if it is negative, you don't have to do anything. But if
Anything,
it is
yes, sir.
positive again, of course, you have to go for um,
Colposcopy guided.
colposcopy guided biopsy.
Mm,
Okay. So
mm,
a pap smear,
mm,
where you don't have liquid based cytology, a
mm,
liquid based cytology wherever it is there, and what is that called, HPV DNA, whenever you have a good indication, and colposcopy. We should know about these things, and we should
mm.
also know how to read the pap smear report,
Good.
and we should ask our pathologist to report it in Bethesda system. Okay.
Yes,
So
sir.
we do get our report in Bethesda system. You have seen, of course.
Yes,
So
sir.
there, it becomes very clear what he wants to convey, whether he is conveying only inflammation or any cellular changes because of inflammatory or infective possibilities, which can be bacterial, which can be viral, or which can be anything. Okay.
Yes, sir.
And whenever there is a dysplasia, and he has to tell it very clearly, describe the cells, what kind of cells he is seeing, whether
Mm.
he is seeing glandular cells, or whether he is seeing epithelial, I mean, what is it, squamous cells, and what kind of dysplasia he is seeing. Depending on that, you have to go for further modality. Okay, this is I think we should have a proper one session on screening part. Okay,
Yes, sir.
I
Yeah.
think some other day, one of us will do that.
Okay, sir. Will do.
Okay, any more
It's
questions?
more of opportunistic screening, sir, now. Like
Yes.
whoever gynec patients walks in, we're going to counsel them about it and just do the pap test.
Yeah.
And one more thing, as you said, because of the resource restrictions, now they're coming up with single doser. they're like, at least even if these adolescents are given one dose of vaccine, it might be more beneficial than not receiving the vaccines. It's yet to be approved, but they've recently mentioned in the Foxy guidelines.
Yeah, yeah. This is always there. No, something is better than nothing.
Nothing. Yes,
But
sir. Yeah.
but let us not go into the controversy of vaccines, because vaccine is pretty controversial.
Yeah.
I mean,
Yeah.
barring very few which have actually given very good results, which are visible results, like polio, like
Yeah.
smallpox,
Mm, mm,
measles. But
mm.
barring few, many are, for example, what is that called? The varicella vaccine and
Vaccine. Mm, mm,
other
mm,
things have not proved to be great. Huh? And the
mm.
BCG, even though not proven anything, but still continue to be given in a very national way, in a national
Yeah.
level, and that to every child without much
Correct.
proven benefit. But let us not
Yes.
go into that. But I think
Mm.
so. This personally, I would recommend this to my patients. Uh, but only thing is, with a word of caution, that please do remember to continue screening.
Mm.
Okay.
Okay, sir.
Yeah.
If
Anything?
anybody else in the group is like giving it prophylactically or actively giving, I just want to know, like,
Yeah. No, please do ask questions or want to give comment. You can unmute yourself and start speaking.
So which vaccine are you suggesting for patients that walk in? So like recently my cousin called me that she is 14-year-old already. So the school has been recommending this vaccine. So what do you suggest? They had called me. So I'm
Yeah, that's
like,
what
yeah, you can take it. Yeah.
no,
So which one are you suggesting, sir?
quadrivalent, of course, Gardasil. Okay.
Okay, sir. Okay, sir.
Quadrivalent, because those four are the most prevalent these things.
Mm.
So as Manasa said, I'm also a little reserved about the Indian made one,
Yeah.
just because, not because it is an Indian made, but because it has come very new and we don't know.
Nice.
Yeah, and you know what has happened with COVID vaccines, no? I mean,
Yeah. Yeah,
we
sir.
all took three shots, and then now we are living in practically fear. When I'll have a stroke or when I'll have MI, we don't know. So
True.
yeah,
Yeah,
sir, I
sir.
so that,
find two things different about this vaccine. See, as you said, even BCG, other things are given. There is no screening or anything. Just give and just finish it off at one stop. Whereas this requires vaccine, second thing. And one more thing, we don't know the extent of side effects. There was one discussion in the gynae group telling, I mean, one part of the people were telling it might cause ovarian insufficiency or something later. So it is very difficult to actively recommend this vaccine. And even when I look at their trials, the sample is small, sir. It's just 25,000 people or 15,000 for each vaccine. And they're all adolescents, so it is going to require a long time to just prove the safety of this vaccine.
yeah. See, the Western countries, they have conquered, I would say, conquered the word cervical vaccine, cervical cancer, not by vaccination, but by screening.
Mm.
Okay.
Mm.
So even our statistics, what do they say? E- Even in once in a lifetime, if a woman undergoes a pap smear or forget about pap smear, even a perspeculum examination, her
Mm.
chance of dying from cervical cancer comes down by 50%.
Right.
This is a staggering number. See, do you yes, a per speculum examination, because you all know woman comes to you by the time, I mean, by the time you diagnose, majority of the patients are inoperable.
Right.
Correct.
No one has even put a per speculum. I mean, nobody has done put a speculum, not even done a per speculum. So in Kidwai Memorial Hospital, they
Yeah.
have a protocol where the cervical cancer patient first goes to radiotherapy.
Okay.
Somebody refers a patient of CS cervix. They don't go to gynae onco. They go to radiotherapy. There,
Mm.
when they say, okay, it is not for radiotherapy, then they go to, what is that, gynae onco. The radiotherapy people will do biopsy, they will do the CT, they will stage the disease, they will take up for radiotherapy because majority of the patients are inoperable.
Right.
So this is what is the situation in our country. So that is why even after almost nearly decade plus of vaccine, I'm a bit skeptical, and I still believe that a good screening is what is really required. So see how many of our own gynecologists have got the pap smear done. You tell me. It is dismal number I am telling you. So this has to be more propagated rather than vaccine, but I'm not telling don't give vaccine, but then, I feel that we should promote more of screening and proper way of screening.
And even a per speculum examination also has come down, sir. After sonography is there in our
Yeah,
OPD,
that
we
is
just put
another
a
problem.
sonography.
Yeah, exactly.
TVS we
Yeah.
do directly. In
Yeah.
PG days, we used to first put a speculum, do PV examination. Now it is
Right.
like we just put a TVS probe, and we are also missing the per speculum part actually now.
Yeah. See, what has happened is now we are putting per speculum examination only for patients with wide discharge PV.
Yeah, yes, sir.
Somebody
Yes, sir.
complains, then only you put the speculum. Otherwise, most of the time, either you do PV or worse, you
Yeah.
fully transvaginal scan.
Yeah, sir. Yeah, sir.
Yeah, and what has happened is, Manasa will agree with me. Many of the patients with vaginismus and all that have been diagnosed by examination, and proper treatment as they made them conceive, because people have done HSG, cystoscopy, laparoscopy, but they have not conceived because they are not having intercourse. So we have forgotten that art. Anyway, that's a different discussion altogether. Forget it. Any other questions? Comments?
Sir,
Gardasil 9 available in India?
Sorry?
Is Gardasil available in India?
yes, sir.
Yes,
Yeah, it is available.
Sir, I
Okay.
want to add something, sir.
Yeah, Rajana.
Sir, when I wanted to take this Cervarix, this vaccine, so I had called Praveen Rathod, sir, when he was there in,
Yeah.
sir. So what he told about vaccines was, don't go for vaccine which has more number of, like now it is going to, like Gardasil 9 covers more of the HPV viruses, which are less common. So go for the most common, like be it Cervarix, it was Cervarix only for two most common.
Yeah.
So the more the number of this thing will create a lot of cross antigenicity. So they might have more adverse effects. Be simple, and which is most common, you go for it. That is what he told, sir.
Okay, fair.
Agree, sir, because 16 and 18 covers 50% of the incidence of
Yeah.
cervical cancer. So it is more logical to think that way.
Yeah.
That is what. After that, sir, only we went ahead with Cervarix. Yes,
Sir,
sir.
and I should also tell you that sir had gifted ma'am the vaccine, cervical vaccine. That's when we started thinking, should we all take
Oh,
before marriage, I guess.
nice.
Yes, sir.
So
You
will
can
you
expect Raja to
describe
do
it?
such things, no?
Yeah,
No, sir,
yeah.
marriage was kept after 8 months, so I decided 6 months what to do. 6 months. Yeah.
So will you tell your boys to take, like, you have
Yeah.
boys.
We are considering. Actually, Shilpa was telling. So we are planning to vaccinate both of them with HPV vaccine. Yes.
Okay,
She's
sir.
a pediatrician, so so she
Oh.
said.
Okay.
Okay, if there are no comments, I think Anusha should start her talk.
Yes, sir. Yes, sir.
I'll make you co-host so that you can start, Anusha.
Yes, yes, sir. Yes.
1 minute. Yeah.
Okay.
Hey, Pramod.
Actually, I'm doing it from phone. Okay, sir. I'll explain.
I can share it. I can share the presentation
Why?
if you want.
Yeah,
She's
ma'am.
doing it from she's doing it from phone, it seems, sir. I'm not sure.
Okay, you do. No, wait.
I'll share. Yeah.
Anisha, stop sharing.
Stop sharing,
Okay,
yeah.
sir.
You stop sharing.
Yes, sir. Okay, so today I'll be talking on contraception. Mana, can you just? So when I thought to what to speak on contraception, I had how to divide, because it is such a wide topic. I thought how to divide this topic. So I thought I'll divide it based on the age group that women come. So contraceptive choices for young women, then post-abortal contraception, contraception after postpartum contraception for the women over the age of 40 years, male and female sterilization, and what are other special occasions like overweight, obesity, and contraception. Contraception for cardiac diseases, or in patients with HIV, or in patients who have or had breast cancer, and what are the drug interactions with hormonal contraception. So first, I thought the most common one that we encounter in our day-to-day practice is the post-abortal contraception. So which we tend to forget most of the time, which I do actually. I also tend to forget counseling the patient or, about the contraception. So regarding the abortion care, so the post-abortal contraception is a very integral part of it, because the ovulation can occur as early as 8 to 10 days after spontaneous or induced abortion. So most women resume sexual activity within 2 weeks after the abortion. So, but in certain situations like septic abortion, it can be delayed, like in case of insertion of IUD can be delayed in septic abortion. So according to CDC, the categories has been divided into 1 to 4, 1 being the safe contraceptive method and 4 being the contraindicated method of contraception. So, but the most methods are usually category 1. So first we have to do is a counseling, which has to be patient-centric, and we have to understand what are the priorities of the patients, what are the goals of the patient, and then taking into knowledge about all that, and then we have to offer the contraception instead of pressurizing the method that we commonly follow at our OPD or something like that. So we can explore patients' prior contraceptive method also, so that we can offer the same contraceptive method because she'll be comfortable with the particular method of contraception. So coming to the contraception, so the most common one that we do is combined hormonal contraception. So it is category 1. It is safe in both first and second trimester abortion as compared to the postpartum contraception, because it is contraindicated in the first 6 weeks of post-delivery because of the risk of venous thromboembolism, because the lower levels of the hypercoagulable factors are present in first and second trimester. So we can offer post-medical abortion as well as post-procedural abortion, both first trimester as well as second trimester. So when this has to be given to the patient, so we can give on the day of the day we give mifepristone, that is on the time of initiation, or we can give on the day 1 of the next cycle. So even if we give it on the day of mifepristone, there is no difference in the bleeding days or in the duration of bleeding. In post-procedural abortion, we can, but in sometimes post-procedure, there can be decrease in the duration of bleeding, so which we have to counsel for the patient. So it can be initiated both in the post-medication, post-procedural abortion, as long as they don't have any contraindication to the estrogen use. So next we have is the progesterone only pill. So this is also category 1, can be given to women where there is a combined oral contraceptive method contraindication. So the one thing that we have to counsel is about the irregular bleeding, which we see with all the progesterone method of contraception. So when this has to be given, it can be given on the day of mifepristone, or on the day of the procedure, or on the day of the next menstrual cycle, that is the delayed initiation. So next we have is the injectable contraception. So which we commonly follow, injection medroxyprogesterone acetate will be given, IM. It can be given to the gluteus or deltoid every 3 months. But sometimes what happens, the patient might not return after 3 months. So we can advise them to have a self-administration of this subcutaneously every 3 months is also safe, like how they take insulin injection at their homes. So so that continuation rates are higher. So one thing we have to counsel is about the irregular bleeding. But some patients might also have 1 to 2 kgs of weight gain also. So when has to be given? It can be given on the first day of the next cycle, or on the same day of mifepristone, or on the day of the day we'll be doing the procedure. So one thing we have to, some studies have shown that if we give on the day of mifepristone, there can be a risk of continuation of pregnancy. So which is around 3.6% versus 0.9% if it is given, so this has to be counseled. But if we counsel this, that the pregnancy might continue, so women might not opt for this injectable contraception. So on the day of procedure, it can be given. On the day of first or second day of next cycle, it can be given. But I don't know what to do if on the day of mifepristone. Next one. So next we have is implant. So the implant that is available in India is Implanon. It is a long-acting reversible contraception. It has etonogestrol. It is 4 centimeter opaque, radio-opaque rod, which has to be inserted subdermally over triceps muscles. It offers contraception for 3 years. Training is recommended to insert this on the same day of mifepristone administration. So side effect is irregular bleeding, for which patient might discontinue. Intrauterine devices, these are also long-acting reversible contraception, safe, effective. It can be hormonal, it can be non-hormonal, immediately after first or second trimester abortion, or at the follow-up appointment also can be given. But if it is given immediately in the second trimester, slightly higher risk of expulsion rate is present. So if patient is taken medical method of abortion, so when should we insert this intrauterine devices? It can be done after pregnancy expulsion. So how do you confirm? Means when we confirm that there is no pregnancy by ultrasound or UPT is negative, then we can insert the intrauterine device in OPD. Next one. But some studies have shown that if the patient comes after 1 week, there can be a very thick endometrium on ultrasound. So that is associated with increased expulsion, but that study did not show what is the thickness of the endometrium. So and one more study where they showed 1 week and 4 week insertion of intrauterine device had the similar expulsion rate. So we can give if we prescribe mifepristone and misoprostol in this week, next follow-up when they come for OPD, we can do ultrasound. If there is no return product, then we can insert intrauterine device in that next follow-up. Next is barrier methods. So this is also category 1, safe, easily available everywhere, and prevent sexually transmitted infections. So others are diaphragm, cervical cap. I don't know how many prescribed diaphragm and cervical cap to Indian people. But one thing is it should be used along with spermicide and has to be left in place for 6 hours. Unsuitable for second trimester abortion till cervix comes back to the normal size. Next is fertility awareness method. Tracking, here we track the menstrual cycle, identify the fertility window. We ask the patient to abstain in that fertility window or use any barrier methods. So how do we assess the time of ovulation? By knowing the menstrual cycle length, calculate the approximate ovulation timing, basal body temperature, cervical mucus texture, or using LH kits. So nowadays we all have this app in phone where we track the fertility window. So we can educate the patient regarding such apps and make them download these, and you can monitor the ovulation and fertility window. So it is very effective, but needs a very high level of user involvement. Cannot be relied before the first cycle of a post-abortion. So next is permanent contraception. I think that is for one more this thing. So take-home messages. I think where I lack is doing a counseling that we tend to forget. So I think in counseling is a very integral part of abortion care. Whatever method is okay that you're comfortable prescribing the patient. So it has to be a patient-centered approach. Yes, sir. I'm done.
Yeah, nice. Actually, Anusha, I was expecting you to also enumerate on
Post.
the type of progesterones. Like, you have oral contraceptive pills with
Okay.
desogestrel,
Right, sir. Right, sir.
levonorgestrel,
Yes, sir.
what is that? Cyproterone acetate,
Yeah,
drospirenone, and other things.
Yeah.
And how do they vary? Okay.
Okay. I know.
Because it's very important. It's very
Right.
important because the type of progesterone. See, Restol like ethinyl estradiol is constant. Only
Right,
the dose
right,
will
sir.
vary whether you are giving 20 or 30 or 35.
Right,
But
sir.
the very important thing is how do we play with the progesterone component of the OCP? Okay.
Right, sir.
Okay, because some are good as who work very well for patients with obesity.
Right.
Some cause water retention. Some are very good with cycle regularity. Some cause more spotting. All
Right,
these
sir.
things I was expecting you to do, but then we will tackle that some other time. Okay.
Yes, sir. Yes, sir.
So let us come one by one. I'll give one comment each on each thing.
Yes.
Number one, oral contraceptive pills.
Yes, sir.
What is very disturbing is patients don't know that they have to take it regularly.
Right.
Whether you give it for AUB or you give it for contraception, missing 1, 2, 3, they think it is okay.
Yeah.
And they sometimes restart, sometimes they don't restart. When they miss 2, 3 and they get spotting, they'll stop whole thing. Okay.
Yes, sir.
And that is where your treatment fails. Okay. So
Right.
that is why it is very important that you have to tell that, okay, these 21 days you take and then give a break of 1 week and restart. Okay.
Yes, sir.
There are 2 ways of counseling. One is you tell them that, okay, you take for 3 weeks, that is 21 days. And for example, you stop the medication on Thursday, let us say. Okay.
Yes,
now, next coming Friday, she restarts. And not the next day, I mean, the next Friday.
Yes, sir.
She restarts the whole medication again. Whether she gets the menses, doesn't get the menses. That is one method, which is very easy and which is very easy to explain. Okay. Other way is, of course, you after you complete 21, then you get the menses, and then you start on day 3 or day 2 or day 5, depending on your convenience. Okay. Now that is very confusing because some women will have bleed, which will be very less. So she thinks this is not the actual bleeding I should get.
Right.
Which will be very little spotting. Even few drops is bleeding for us, but for them, no. So then they will wait, then they get pregnant. Or if you are treating for AUB, then they'll have whatever, heavy bleeding or whatever, then they come back. So these are the practical things which we should tell. Okay.
Right.
Other way of giving oral contraceptive pills is you can give contraceptive pills continuously for 4 packets.
Right, sir.
That is 84 tablets. Then take a break, take a withdrawal bleed, and then again restart. Okay. Now that was those days in some countries it was available as seasonal, but now it is not available. I think it is not in the market, but we can prescribe this for some women.
Right, sir.
All of you, please mute yourself. It is disturbing in between. Please mute yourself. Okay. So,
but the people are obsessed with that menstrual cycle. They want that.
Yeah. That's what I'm coming. See what happens, especially when you counsel them, sit with them. A woman has to see what does our standard textbooks of gynecology say? A woman has to bleed at least 3 or 4 times in a year. That is enough.
Yes.
If that much of endometrium shedding happens, that is enough. Okay.
Right. Yes, sir.
So that is important. If you tell them the scientific basis, so they will agree.
Right.
So of course you have to understand that what kind of patient you are talking to, what kind of patients you are counseling,
Class.
all these
Yeah.
things do matter.
Right, sir.
Okay, this is about seasonal. I do give this kind of seasonal in patients with AUB,
Okay.
who are like young patients, but then but they have come with heavy bleeding and anemia. Then you give them for 4 months continuously, they don't bleed, and meanwhile you give FCM vagara vagara, and then they do really well. But
Right.
it works. It works. Okay.
Yes.
And there is no increased incidence of DVT or anything because you are giving continuously. That is very important.
Yes.
Okay.
Yes.
Now coming to progesterone only pills, they have not become popular for a reason in India.
Irregular bleeding.
Irregular spotting. Okay.
Yes, sir. Yes, sir.
And same thing holds good with DMPA also.
True, sir.
And DMPA also, it is very difficult to counsel them that this is common. So DMPA I use only in 2 situations.
Okay.
Number 1 is after delivery, because in any case they will have irregular bleeding because of lactation. And you tell them that, okay, listen, this is what it is, but it is reversible. Anyway, you are not going to get regular cycle. So they accept it. At that time,
Yes.
acceptance is good.
Yes, sir.
So they do accept. Fair amount of people do accept. But then, as you said, obsession of getting menses is very high, even in my practice, obviously.
Yes,
Okay.
sir. Yes, sir.
Now, second situation where we use DMPA is for endometrial hyperplasia.
Okay.
Now, patients with endometrial hyperplasia without atypia, for sure, without atypia. Now, the dosage is different. It has to be given once a month for first 6 months.
Okay.
Not once in 3 months.
Okay, sir.
Endometrial hyperplasia requires good amount of suppression, so it requires good amount of endometrial, good amount of progesterone levels.
Right.
Okay, so we
Okay.
give every month. After 6 months, you may make it every 3 months if she is already amenorrheic, and you do follow-up scan which gives a lesser endometrial thickness.
Okay. Okay, sir.
This is what I practice.
Okay.
6
Then why
months.
not put Mirena instead, sir? In
No,
OPD?
some women don't accept Mirena, or sometimes Mirena gets expelled.
Okay. Okay.
See what is some women, the moment you say you are going to put, says copper tea, no, they say no. Even though you tell that, okay, there is no copper, it is not like that, but then they associate that with copper tea and then they say no. So that is the
Okay, sir.
problem, of course. And moreover, Mirena does have about 10% or 20% expulsion rate, especially if you are
Yes, sir.
dealing with very big uterus, something which
Yes,
is
sir.
10 centimeters, adenomyosis, somebody who
Yes.
gets very cramps, somebody who has already passed a cast or whatever
Yeah.
like that, they have very high expulsion rates.
Expulsion rate. Yes, sir.
So you have to, so sometimes nowadays what I'm doing is I do give a shot or 2 of the dipomedroxyprogesterone. So by that time they would have also sink in, and then bleeding stops, and then you put a Mirena and forget it.
Okay.
After
sir.
2 or 3 2 or 3 injections of DMPA, then by then bleeding would have stopped and they will be receptive. They see that, okay, it has given a result. So then they agree for a Mirena.
Whatever you counsel. Okay. Yes, sir.
Yeah. So that is the another trick you can do. Okay.
So instead of using Lupride, we are using DMPA, which is cost effective also, sir. Here, what they
Yeah,
do, they
but
put Mirena also and give Lupride also, for big uterus.
that works well. That works well. The Lupride, especially in where there is a myohyperplasia, Lupride
sir.
might work. But I don't give Lupride because of the cost.
Okay, sir.
Yeah. And whatever you do know, when you put Mirena, you have to cover that with something, either OCP or DMPA or Lupride or whatever, or even medroxyprogesterone twice a day for say 1 month, 2 months, like that. You have to cover it.
Yeah.
Very few people would get relief immediately after you put a Mirena, because Mirena does take time to start working.
Okay. Because recently I had one patient where I put Mirena, put it on norethistyrone also, sir. After 2 months of taking, she still expelled the Mirena, and
Yeah.
she changed the doctor next.
No, that
And-
happens. That happens. I
Yeah.
mean, that happens. That happens with us also. That where a patient comes out with a Mirena in her hand. He said,
Yeah.
we spent so much, and then it has come
Yeah.
out. Now what should do? So, and then you give. Worst thing is, you
Mm.
give DMPA, it works, and she says, when this cheaper injection was working, why did you give that? So,
Correct.
it happens.
Correct, sir.
Okay. Now
Yes.
another thing about contraception going on. Now, when I do get women who are 35, 38,
Mm.
who come for tubectomy.
Right.
For some reason, they don't get tubectomy done after their first or second child or whatever, but they do come, but they have no problem. So I tell them that instead of going for sterilization, I mean, even though laparoscopy may be simple, but then still it is invasive. For those women, I suggest Mirena, not the copper T.
Okay.
For a reason, because that is the time they are going to get disturbance in their menses.
Menstrual cycle.
Some women do, some may go through without comment. And then once you put a Mirena, somebody who is 38. So I tell them, listen, 5 years it works, and 43, 44, you just remove it and throw it off. Your chance of getting pregnant is, I mean, very, very less, very, very less.
Nice.
Okay, that is another thing which we practice, because giving an invasive procedure is still can be avoided.
But that amenorrhea after 6 months, that patient will be okay, sir. To conceive.
Yeah, you have to explain that.
Mhm.
If you explain that it is only acting locally and no hormone is getting absorbed into the bloodstream and it is not going to affect you, many women do accept. I mean, you have to choose again which kind of woman you are counseling.
Yes.
Because somebody who comes to you for tubectomy at 35, 38 usually belongs to upper middle class kind of women who understands these things.
Right.
Otherwise, lower strata people usually, they finish their family fast, and by 25, 26, they are done.
Right.
They are done with their family planning operation. They don't come to you for tubectomy at 35, 36 like that.
Okay.
Yeah, this is another thing. Now DMPA over, what else? OCP over, property. Okay. Now
This,
property. Yeah.
Implant, have we ever
Tell me.
seen someone put, sir?
Yeah. No. I have not. Actually, recently, Family Planning Association President Dr. Mali Patil sir here, he told me that you accumulate 20-25 patients. He will call what that madam's name? Hubli, famous SDM Dean. I forgot her name. Famous. I forgot her name. Dr. Ratnamala Desai ma'am. Yeah, Ratnamala Desai ma'am here to train our people for implant and insertion. But the problem is accumulating 25 patients, counseling them and all that is not easy.
Yeah. Yes, sir. And it is very costly, sir. 10,000, 12,000 for one this thing.
Oh, I didn't know this.
Yeah, that is 10 to 12,000 for one this thing, sir. So
yeah, again same problem. No, see, if they start having irregular spotting and in between brownish discharge. See, many women when they come with repeated spotting. No, I do this trick. Okay, I tell them that this is not bleeding.
okay.
I tell them that this is spotting, which is a shedding of endometrium. That is why it is brownish in color. It's not actually blood. Actually, they are worried about only two things. Number one, about temples, going to temple and all these things, religious reason.
Yeah.
Second thing, they are worried about having an intercourse because in Indian male psyche, you are not supposed to have intercourse with a menstruating woman.
Right, sir.
Okay, these are the two issues they are very worried about. So if you tell them that first, this is not a bleeding, so going to temple, everything is fine. I mean, like they'll be happy. Number two, and you tell them having an intercourse is absolutely safe, no problem. You don't have to worry because this is not blood. This is not
Mm.
menstruation. So most
But-
women are, yeah,
Nice, sir. But most women, even who are working, they are, that irritated with this irregular spotting because of
exactly,
staining of
exactly,
clothes, and then
exactly.
how to, so that is very
Yeah, yeah.
disturbing for them, actually.
That's what. Same thing with Mirena, same thing with DMPA, whatever, any progesterone you give, the breakthrough bleeding has to happen. You are
Yeah.
lucky if the woman gets amenorrhea.
Right, sir. Right.
I mean, doctor, I'm telling.
Yeah.
A doctor is
Yeah.
lucky
Yeah.
if woman goes into amenorrhea. So you have to
Yeah.
counsel them. No, absolutely fine. The moment I pull it out, you're going to have normal. So they'll be happy.
Yeah.
So that is why I have not explored the implant part. But then if somebody is practicing, please do give feedback. What else I wanted to tell? Anything else we have covered?
IUDs.
Yeah,
Like
that's what
copper
IUDs.
Mhm.
Yeah, copper part. Now, see what has happened is, I don't know for what reason, lot of women, even those who are willing to get copper T inserted,
Mhm.
gets inserted with a negative mindset.
Yeah.
So any bloody pain or backache, they attribute it to copper T.
Yeah.
So after through 2 years, 3 years, also sometimes for some stupid reason they get backache, but they attribute it to copper T.
Yeah.
So that hyped up complications like migration or
Mhm.
having PID and
Yeah.
all those things has put a lot of negative thing on copper T. That is why, and moreover now the worst is the PPIUCD program. What has happened is in government hospitals, sometimes I don't know whether they have told them, whether they have not told them, but women don't know that copper T has been inserted.
Yeah. So this week I got 2 patients where they didn't know the copper T was
Yeah.
inserted. So they came,
Yeah,
I want
and
to check
then
it.
yeah, and what has happened is, though on paper PPIUCD is supposed to be only inserted after the proper counseling, but because they have targets to meet, they'll tell that if you don't agree for PPIUCD, we are not going to do section. Now they forcefully sign it. Now after that, either they forget it or whatever, I don't know, God only knows, and they come back with some reason, and then you detect it. So because of that also, copper T is kind of a negative intonation. But for right amount of people, if you put multi-load under good aseptic measures, and my usually I do put 3 days of antibiotic cover after I put the copper T.
Okay, sir.
So just in case, okay, because anyway you're going through the vagina and you're going to put up and all that. Even Mirena, I think we do give 3 days of doxycycline or something like that. Okay.
Okay, sir.
So this is about copper T. What else? Anything
So
else you wanted to?
post-medical abortion, you are putting, sir, like post-abortion, they come for just a scan to look for RPOC. Are you putting
Copper T no.
Yes.
Copper T no, but OCPS.
OCPs? Okay. So from when
OCPS
are you starting, sir? From first day of cycle?
Copper T, I usually give a break of 1 month.
Okay. Even OCP, sir?
OCP, no. OCP, if it is post-abortal, the day we do a check scan, we call them after 3 days for check scan, where to see that it is all gone. There, from that day itself, we start OCPs. And as you said, after MTP, very immediately we put OCP and send them.
Okay, sir.
But on the day of mifepristone, I'm not very comfortable.
Okay.
See, today you take mifepristone and then start OCP also, no.
Okay.
That I don't do.
Okay, sir. So after you're sure nothing is there, she's not pregnant, then you start immediately on OCPs.
Yeah. Okay. Yeah. Any comments or questions, please? Unmute yourself and ask questions.
Hello. Good evening, sir. Deepak here. Sir,
Hi, Deepak.